My name is Karen Brown. I'm the Medical Director of Primary Care at Northeast Medical Group, which is part of the Yale New Haven Health System. And I'm joined by my colleagues who I will introduce shortly. You're joining us for Smilow Shares with Primary Care. Smilow is the name of our cancer center. And this is a monthly series let's say it's more or less monthly. We break over the summer, where we break down not just specific cancer diagnoses, but really the interface between primary care and oncology care. So looking at how things come to diagnosis and how and the intersection between care and then return to primary care. And I'm still seeing a kind of not a presenter mode. Renee, there we go. That's good. Thank you. And now I want to both welcome you and begin to introduce our speakers. So I will start with Ann Chang, who is my partner in this collaborative talk. She's a co-course director. And Dr. Chang is an associate cancer, she's the Associate Cancer Center Director and a practicing thoracic oncologist. She specializes in lung cancer, conducts clinical trials on that, and is also one of our most valued clinicians. Right in her introduction that she shares with patients is that listening and guiding patients when they have cancer is so important. And what I will tell you is she has also taken the time to listen to us in primary care, listening to us and guiding us in how best to help get patients from a point of unsurety, diagnosis, not knowing, and into oncologic care. She is incredibly well trained. We have a theme of basic science degrees progressing into clinical work where she has a PhD from Harvard and then transitioned to having an MD at Cornell, trained at New York Presbyterian and Memorial Sloan Kettering before joining us at Yale. She's joined by her colleague, Gavitt Woodard, who is a cardiothoracic surgeon, also with expertise in lung cancer. She also has a basic science degree in neurology with a healthcare policy degree from Harvard. And then got her medical degree at Stanford and trained at UCSF. She has already won awards and has a booming clinical practice in addition to research here with us. I'd also like to introduce Beth Allard, who's my colleague at Northeast Medical Group. Beth is an outstanding primary care clinician who is well regarded by all of her colleagues. And I have misplaced everything. Isn't that funny? Hold on 1 second. Okay. She practices in Waterford, Connecticut. She began her training at Brown, where she has an MD and a PhD in pathobiology, and again, migrated towards clinical care. She changed course, and in residency, she did family practice at UMass Worcester. And since then, she's been providing primary care for children and adults in her region. She enjoys the practice of balancing medicine across the ages. And she also enjoys assisting with practice manager and is one of my key advisors in the primary care world at Northeast Medical Group. And with that, Beth, I'd like to turn over to you to introduce the first case.
Absolutely. Thank you so much. So it's a pleasure to be back in the Smilow Shares environment and want to thank Ann and Karen again for inviting me to do this. It's been a pleasure to meet a new colleague, Gavitt, and work again on a different form of cancer. I feel like this form of cancer is the one that hits the history books that we all think about. It's the one we learned about in medical school. It's the one that we linked to something. And lung cancer, as we see now, I mean, it's 2024, and this data may not exactly reflect 2024, but this is still the most common cause of cancer death in our country for men and women. We have so many other cancers we're making leads on, and we are here too, and you'll be excited to see some of the things that are happening. 90% of all lung cancer is still linked to tobacco abuse, to use. And that's something that we as primary care physicians have an impact on every day. When we ask our patients if they smoke or not, when we ask our patients if they quit, we are making differences in their lives on this cancer, which is the #1 cause of cancer death in our country. Secondhand smoke exposure also matters and probably increases cancer risk odds by a ratio of 1.21. And then there's some smaller risks that are environmental that we don't see as often, specifically asbestos and radon. And again, accounting secondhand smoke as a possible work-related exposure. For example, people that work in environments where they allow smoking. We don't think of that as a possibility anymore, but it is. Chronic lung disease can also predispose patients to an increased risk of lung cancer. And just think of the turnover in the cellular tissue and the scarring that's occurring when someone has chronic lung disease. But lung cancer risk is real. We know it's smoking related. And as primary care physicians, we'll go to our next slide and talk about how we start the path that rolls to these experts that we have on our panel today and throughout the Yale New Haven Health System. So all of us primary care physicians need to realize that if we have patients that have a history of smoking, we can go to this lung cancer screening pathway and identify those that are eligible to be screened. Anyone between the ages of 50 and 80 years old who has a history of smoking should be identified. And then in the middle of the slide, you'll see that the patient has to meet these 3 criteria. They have to be between the ages of 50 and 80. They have to have a 20-pack-year history of smoking. This pathway so nicely helps you calculate that if you can't, and either be a current smoker or have quit within the past 15 years. And then at that point, you move down the table and move forward with considering ordering their first lung cancer screening. And if they decline to have the screening done, you need to talk about, the fact that they're missing out on screening and consider readdressing it with them. The next slide is going to talk about proceeding with the screening itself. You need to make sure that their smoking history is documented because that's important for our people that are documenting for the approval of the CAT scan, and then the CAT scan can be performed. And what's really awesome to end the health maintenance pathway is that the lung cancer screening can be part of our health maintenance reminders. So now every year when that person is due, it comes up on their health maintenance. 2 other pathways related that I thought were worth mentioning for all the primary care folks that are listening. #1, a whole smoking cessation pathway, because we know that's still such a key portion, and it's good for us to know what are the latest, greatest things for quitting smoking. And also a lung nodule pathway, because we will come across patients with nodules of various sizes, and not every single one has to be biopsied. And for us as primary care physicians to work through some of that, our radiology partners often tell us, like, this one needs a 6-month follow-up. But I think it's good to have access to the pathway. So now we'll move on to our first case. And I want to emphasize that it brings to light, again, that you see the smoking relationship here. You're also going to see through these cases the advantage to having the CT scans done. So our first patient is in many ways kind of that classic smoker. He's a 47-year-old male patient with a 2 to 3 pack per day tobacco history. He presented to my office and said the middle of his back was sore. And like a typical primary care provider, I focused on the middle of his back. The exam revealed tenderness in his right thoracic back. I decided to prescribe him some pain medicine and some muscle relaxers, but he came back. It wasn't just a little muscle strain. When he returned 2 weeks later, he said the medications had not been helpful at all. He was noticing some increased difficulty of breathing. He had facial swelling. He had reduced breath sounds noted on exam. I did some lab work and realized that his D-dimer was positive, his CBC had a high normal white blood count, and his kidney functions were normal. Obviously, I was now turning myself from thinking it was just a muscular issue to something internal, and obviously with the elevated D-dimer, he was going to need a CAT scan. On the next slide, you'll see the results of his CAT scan, which will be discussed in a little more detail in a minute by Gavitt, but basically, unfortunately, severe, bulky, confluent mediastinal adenopathy extending into the right parahilar and right paraspinal region, severe narrowing and possible invasion of his superior vena cava, multiple pleural and parenchymal-based nodules are seen. doesn't have a blood clot, amazingly, with the cancer that appears to be in there, and has indeterminate sclerotic densities within the thoracic spine, which could be degenerative or could be bony mets. So this gentleman's back pain turns out to be the thing that we all wish it wasn't. He underwent biopsy and was determined to have a non-small cell lung cancer and adenocarcinoma. So now I'm going to transition us from the primary care view over to the thoracic surgeon view and ask Gavitt Woodard to continue the discussion. Thank you so much, Dr. Woodard.
Thank you. And thanks for the opportunity to be here to talk about lung cancer and raise awareness. So when we see patients in the thoracic surgery clinic, they're usually been sent to us because they've had some sort of abnormal finding. Sometimes we see them and they've already had a biopsy done. Sometimes we see them and all they have are just a nodule that's been found, and we can take the workup from there. So in this case, we have a patient who already has a biopsy proven lung cancer. And so when I see them as a surgeon, the things that I'm trying to assess for are, what stage are they? Is this something that I would consider to be surgically resectable? Or is this a case where I need to start pulling in my colleagues from medical oncology or radiation oncology immediately? When we have cancers that are stage 1, which is not the case with this patient, our local therapies for them can be surgery or they can be radiation therapy. And generally any patient that would be resectable in a stage 1 setting, we offer surgery if we can. And for those that don't want or can't have surgery for whatever reason, they can get treated with radiation. When you have a more advanced case like this one, we need to first figure out if it is something that might be surgically resectable. And so in this situation, there are some concerns for bony metastases, which would make someone unresectable. Also, based on the CT scan, there's a lot of invasion into different structures, the SVC, very bulky adenopathy. So this is a case that's a little bit more advanced locally than we would be able to resect in this patient. And so I would say the good news, if we want to go to the next slide, I frequently see patients with my colleagues. And so Anne and I have clinic together, which is really nice because then we can see patients together at the same visit at the same time, and expedite their workup and their evaluation by 2 providers in a way that really focuses on the patient care and patient preferences. I think this is much easier for patients. They don't have to come in for 2 visits. So in terms of surgical considerations, we need a staging workup. Usually this is at least a CT scan and a PET. We frequently now biopsy lymph nodes in patients, even when there aren't concerns for lymph node involvement on CT or PET. So if it's not obvious, we would get some sort of nodal evaluation. And then we think about if they're resectable or not. And in terms of resectability, there are 2 things that we think about. One is can we take this out completely? And then the other thing is this patient healthy enough for surgery? And that ends up being something that frequently makes the decision for us if someone has smoked a lot, doesn't have healthy enough lungs, or just isn't medically operable. So for this patient, like we talked about, not a great surgical candidate. And so conveniently, I would have seen them in clinic and I could pass them over to Anne in the same setting, and she can talk to them about the other options that they would have besides surgery.
Great. And it's such a pleasure actually to be a panelist this time instead of listening. I mean, that's fun too, but and again, I encourage you to submit any questions that you have in the chat, and we will try to leave some time at the end. You guys always have really great questions. So multidisciplinary care is sort of a big word, but it's what we do all the time now. So, I mean, in tumor boards, we have so many different disciplines present, and we find that that's really what we need to do in order to take the best care of our patients, is to have that conversation. So from the medical, and I think we achieve the best results when we can actually use combined modalities. If we can do surgery and follow with systemic therapy, like chemo or immunotherapy, and do radiation if it's appropriate, that's when we're going to get our best results. So from the medical oncology side, one of the first things that I'm thinking about is, what is the performance status of this patient? So is this somebody who's independent in their ADLs, activities of daily living? Do they Are they taking care of other people, as many of us do? Are they working? Do they have symptoms? Are they getting out of bed? So those are the things that you need to think about from the viewpoint of, are they that sort of risk benefit ratio for any kind of treatment that you're weighing, whether or not the benefits are going to outweigh the toxicities and risks. Comorbidities play into that. So if they have other major issues, obviously if they have autoimmune diseases, that may give us pause in using immunotherapy. If they have major issues, just had an MI. I had a patient that had a CABG recently, and because of an NSTEMI, and so we wanted to hold off on chemotherapy for a little bit. The histology plays a great role, a large role. In this case, adenocarcinoma. And the PD-L1 status, which is a marker for whether or not it's helpful to understand what prognostically if they're going to respond to immunotherapy, or if you need to add chemotherapy. So if they are PD-L1 negative, it's not that you can't give something like pembrolizumab or Keytruda. It's just that you'd have to combine that with chemotherapy. If they had a very high PD-L1 status, I've seen some patients with 90% or even 100% of their tumor proportion score is positive, then those are folks that might be able to respond to single agent monotherapy with pembrolizumab or an anti-PD-1 agent. And then tumor profiling. Nowadays, we can do this on the tumor tissue, but we can also do this through a liquid biopsy, through the blood, which often comes back a little bit earlier, and we can identify, especially in a never smoker or somebody who's not smoked very much, whether or not they have a driver mutation like EGFR or ALK or ROS mutations or abnormalities where they could actually take a pill. We have up to 10 mutations where we can actually give a targeted therapy for that, and that's super exciting. That's happened over the past 10 years and changed. Even with smoking related tumors like KRAS, we used to think that was always undruggable, but actually KRAS G12C, that particular mutation, has a drug that's for patients who have that particular mutation. So these are the considerations that I have in my mind when I meet the patient. And so I think we will now go to the next. Oh no, I'm going to hand this back to Gavitt to highlight some of the really exciting advances within the past year.
Yeah, thank you, Anne. No, there has been so much progress made in the care of lung cancer in the last few years with some really exciting drugs. So usually that stays in the medical oncologist realm, but as surgeons, we've had a very exciting era with a lot of big trials coming out that have shown dramatic improvements in event-free survival and overall survival when immunotherapy is used before surgery. So we are highlighting this trial, but as you'll see in a few slides, there are many, many trials in this space that have come out. This is the only one so far to show an overall survival benefit. But this was perioperative pembrolizumab, which is immunotherapy, and it's being given for 3 to 4 cycles with chemotherapy prior to surgery. We then do our surgical resection, and then some studies have been done where it's only given before surgery, and others have shown that these drugs, when given before and after surgery, have a real benefit. So this trial specifically gave it both before and after surgery for patients who had resectable lung cancer. We're doing this now for patients with stage 2 and stage 3 disease. It's not for all patients. So if you have some of these targetable mutations, those patients get excluded from these studies because we have other good drugs that work more appropriately in those patients. But there's been it's a huge new era and a big paradigm shift in the way that we've been treating these lung cancers. We show the next slide. This is what I'm talking about. So this is the perioperative pembrolizumab study, event-free survival, a huge difference in those survival curves. And these are patients where just a few years ago, we wouldn't have even been thinking about surgery in them, patients with multi-station N2 disease. This would have been considered unresectable several years ago. now we have a lot of enthusiasm for our ability to deliver much better survival. And really, it's an exciting era for patients who can get these therapies. And on the right, you see the overall survival benefit in these patients, and really dramatic and impressive overall survival out to, this doesn't go quite to 5 years, but certainly out to 3 years, 80% overall survival at 3 years in a group of patients that would not have done this well several years ago. So it's an exciting time. Next slide. And there'll be a quiz on this one at the end. But this is a lot of details for us to keep straight. I don't think that the point is really that there have been a lot of very similar studies done using immunotherapy. This is for resectable lung cancer, and some of these are using targeted therapy, but there's a huge number of approvals that have come out just in the past few years. It shows you how rapidly the treatment landscape is shifting, but it also, each of these represents a really great opportunity to provide new cutting-edge care to patients, and each of these represents an improvement in some sort of outcome for patients. So I think the point is, it's a great time to be in lung cancer research. We're excited about the possibility of delivering much better outcomes than we have historically in these patients, and there are a lot of different drug regimens that we can use. Next slide. All right, back to you, Beth.
All right, thank you so much, Gavitt. So now we're going to move on to another case and talk about where we can get with screening chest CT scan. So this is a 55-year-old man who has a history of tobacco abuse. He's also had a mitral valve repair, diastolic dysfunction, leg DVTs, and hypothyroidism, who presented to me for routine care, but did complain he was feeling a little bit more short of breath. He denied any cough or any weight loss. He had some blood work done that showed a normal kidney function panel. His TSH was elevated to 22 and his liver transaminases were elevated. So I said to myself, well, he has the thyroid condition. He does have, an elevated TSH, but I'm not sure I typically see that associated with shortness of breath. He was due for a screening chest CT with his history of smoking. And so he had that procedure done, and the CAT scan showed a couple of things. It showed a sinus of Valsalva aneurysm measuring up to 52 millimeters at his right coronary cusp, a thoracic aortic that measured 30 millimeters in diameter in the mid-ascending portion, and he had a 2.2 centimeter enhancing soft tissue within the endobronchial component, nearly occluding the left lower lobe bronchus. It was concerning that it was a neoplasm. Carcinoid was a diagnostic consideration, and it was recommended that he undergo PET scan and CT scan and tissue sampling. So in the next slide, we'll see that he did two things. Number one, I ordered him an echocardiogram because I figured with the shortness of breath and obviously for assessing for his ability to undergo any procedures on the possibly malignancy side, I needed to know what his heart was doing. So he had a fairly good ejection fraction as echocardiogram with an EF of 56%. He had moderate diastolic dysfunction consistent with increase in filling pressure, grade 2, and he had moderate aortic regurgitation. So summary, this gentleman has some heart disease that is possibly leading to some of his symptoms. But at the same time, a few days later, he underwent PET CT scanning, which revealed a mildly hypermetabolic soft tissue nodule adjacent to the lower bronchus, concerning to be a low-grade malignancy. Further correlation with bronchoscopy and tissue sampling was recommended. There was no suspicious hypermetabolic metastatic lesions. So unlike our last case, where this last patient was full of cancer and it was throughout his heart and mediastinum and into the bones and so forth, lungs rather, this is a person that has a fairly small process going on. Bronchoscopy was performed and a fine needle biopsy showed a typical carcinoid tumor. So now let's allow Gavitt to tell us a little bit more about what happens at this point and her role in a patient like this. Thank you.
I think so. This is a patient that luckily seems to be surgically resectable. He's a little bit medically complex with a history, some medical comorbidities, but nothing so far that would prevent us from moving forward with surgery. The other thing that I think bodes well for him is that this is a carcinoid, and Anne will get into a little bit more detail about this, but a typical carcinoid has a great prognosis, and we don't think of these as being tumors that really spread to other places in the body. And so as a surgeon, seeing someone like this in clinic, you get excited about the possibility of doing a surgical resection in this patient, and being able really to provide kind of long-term disease control by operating on someone like this. And do you want to discuss more about different neuroendocrine tumors?
Yeah, thank you. So neuroendocrine, this is my passion, is neuroendocrine tumors of the lung. And that ranges from carcinoid tumors, which are really sort of we consider them almost like benign tumors. They can grow in spots where they can cause some problems, like for this gentleman in the endobronchial component. But typically, if you remove them or if you radiate them, then you just watch with serial scans over time. Sometimes you'll see typical versus atypical. Atypical means that if you're looking, they look like carcinoid tumors. They still have a neuroendocrine component, but they have more mitoses per high-powered field than the typical. So they're just a little bit more aggressive. Again, these can have local treatments, surgery, SBRT, that's stereotactic body radiation or ablation. And one of the things that, especially with carcinoids, is we often will do a PET scan, PET dotatate, because if they're positive, we can treat them with octreotide, just injections on a monthly basis. If you're sort of stepping up to the next level of aggressiveness in terms of tumors, you can have non-small cell tumors with neuroendocrine differentiation. And we basically treat them just like non-small cell lung cancers, but we'll use platinum etoposide doublet when we're using chemotherapy. Large cell neuroendocrine tumors are, again, a little bit more aggressive. We use the tumor profiling because sometimes if they have a KRAS tumor, they have a KRAS mutation, we'll treat them as non-small cell. If they have a RB retinoblastoma or TP53, we'll treat them as small cell. And then finally, small cell are the most aggressive neuroendocrine tumors, but they are extremely chemo and radiosensitive. If they're limited to the thorax or in a place where you can fit it within one radiation portal, then we will treat them with chemo plus concurrent radiation. And the intent of that is curative. And actually one of the biggest advances for limited stage, the first advance within the past, I would say, 3 or 4 decades, it came out this summer, where we actually see that if you follow up the chemoradiation with 2 years of immunotherapy, those patients can do actually quite well. The aim of that is curative. We know that if the tumor has gone to, if the small cell has gone to other organs, such as liver or brain, kidneys or bone, then it's palliative. And then we treat with a combination of chemo plus immunotherapy. But there are new, again, just in May, a new drug out that's a bispecific antibody that sort of brings the it brings the immune system to the tumor cell. And we have some really good responses there. And actually, I'll talk a little bit about that later. But that's sort of the realm. Carcinoid, very indolent, almost benign. Small cell, much more aggressive, but still have a lot of treatment opportunities. And I'll pass it back to Beth for our last case.
So in some ways, this is my favorite case because I think it begins to bring us towards the future of lung cancer treatment and assessment. And you'll hear about that in a moment. There's a term on this very first slide that reminds me of something that feels like a modern world that needs to be talked about more, and hopefully our experts here will tell us. But our story begins with a 57-year-old female smoker with a history of melanoma, tobacco use, as we mentioned, obstructive sleep apnea, presents to me for primary, routine care. And again, because of that history of smoking, like we talked about at the very beginning of this talk, we're using the pathway. We have someone with a significant 20-pack year smoking history. They're between the ages of 50 and 80, and we're pulling that trigger and ordering that CAT scan. The patient said she's feeling well. She has no symptoms. We did some basic screening labs. Nothing was revealing. Normal kidney functions, normal blood count. Went to CAT scan. CAT scan came back with something interesting. Here's the buzzword. There is a ground glass nodule. And the right lower lobe, it's slightly larger and slightly denser than it had been on prior examination. It now measures 11 by 6 by 16 millimeters. So this, again, this is not a big process. It's small, it's vague. Her pulmonologist is concerned about the findings and orders a PET CT scan for further analysis. And the PET CT scan reveals a suspicious 1 centimeter, roughly right upper lobe mass, detailed on the recent CT scans, and worrisome for a possible underlying neoplastic etiology. There is minimal low-grade uptake seen in the lesion. There are no other areas of suspicious neoplastic or hypermetabolic uptake seen. So again, this is a patient who comes in for routine screening and finds out they have this little thing in their lungs. It doesn't totally light up, but it's not supposed to be there. And the decision was made for the patient to undergo right upper lobe wedge resection, which revealed an invasive mixed mucinous and non-mucinous adenocarcinoma. And again, I'm going to turn our interest over to Gavitt, who's going to tell us more about these ground glass phenomena. Thank you, Gavitt.
Thank you. Yeah, this is a nice example of what we are trying to achieve with lung cancer screening, catching things very early when they can be treated with potentially just surgery alone, no systemic therapy, and to nip things in the bud, if you will. So if we want to click through the slide, I think this has some, yeah, perfect. Good stuff here. So what happens when we find these indeterminate nodules on screening? This is the challenge. We don't know exactly what to do with them, especially something that has this buzzword of ground glass. We see a lot of this, and ground glass is different from a solid nodule. Solid nodules we get a little bit more excited about, especially when they have a spiculated appearance. But for something that's ground glass, it can be a lot of things, and a lot of those things are benign. Some of them are listed here. So when we see these patients in clinic, what we tend to do with them is watch these nodules over time and look for change over time that signifies that this is something that we need to be worried about. And frequently, even when we see a lesion persist on imaging over time, we see enough of these, we kind of know what it is. It's a slow growing lung adenocarcinoma, and the question is when to treat this. Many of these patients get observed for years before going on to surgery, and that's one thing that is a little bit hard, I think, for many patients to wrap their head around, is that, well, we think this is, you know, an early slow growing lung cancer and that we're comfortable watching it. But it's true for most of our patients, and I'm going to show you some of our data from our Yale patient population in a bit. But we'll often watch them. A biopsy is not very helpful. PET scan frequently, as was the case here, doesn't show much. They're not fast growing tumors, so they don't really light up on a PET. They're unlikely to spread to lymph nodes, but many of them will go on to a surgical resection eventually. Next slide. And this is what they end up looking like on pathology. So ground glass opacity, ground glass nodule, semi-solid nodule, these are all kind of flavors of the same form of slow growing lung adenocarcinoma. Thoracic surgeons see tons of these. I believe pulmonologists would too. It's just a frequent patient that we see in our clinic. And you can see, I'm showing you the CT scans on the left and what it looks like on histology on the right, but the ground glass we really think of as more a pre-invasive component. I would liken it to DCIS of the breast, where it's not a cancer that we tend to get worried about, but when these tumors start to grow a solid component, that's when we think of them as being more invasive and having the potential to spread to other places. And so really it's the growth of the solid component or enlarging to a size where we think that the treatment is really going to change, that makes us pull the trigger on doing a surgical resection. Next slide. They're really common. This is data from Yale that we gathered, and basically this was a study we did of every single outpatient CT scan done within the Yale New Haven Health System. This includes screening CTs, it includes cancer surveillance CTs, you know, whatever reason, but only outpatient scans. And this is the total number of scans on the left, and then the percent of CT scans on the right, where this finding is in the report. So that's how common it is that any patient walking in to get an outpatient scan ends up with a finding like this. Next slide. And you can see broken down by age and whether or not it's just an outpatient scan versus the red and the green are both the screening population, but very, very common among patients to have a finding like this. Next slide. The good news is people do incredibly well with these lesions. This is a form of lung cancer separate from the other types of lung cancer where the survival is not as excellent, but these are very slow growing. Eventually, when they hit a point that we're worried, we will resect them. Some patients get radiated, but I would say it's more common just to observe followed by resection. But these are Yale patients followed over time, 98% 5-year semi-solid nodule related survival. They are 4 times more likely to die of a future cancer that develops later and kills them. And they're 10 times more likely to die of something else than these nodules. So ground glass opacities and semi-solid nodules, still refer to your thoracic surgeons, but that's something that is nice to be able to reassure patients that it's a different flavor of lung cancer than the other kinds that they might go online and start Googling. Next slide. And the point here, Anne, did you want to take these slides to talk about,
Right.
okay, these nodules are incredibly common, GGOs or ground glass opacities. We frequently find them in women and in never smokers. And so it's a nice segue to start talking about lung cancer in never smokers. 1 in 5 new lung cancer diagnoses is found in a never smoker. And if you were to think of never smoking lung cancer as its own disease, it currently ranks 5th in terms of global causes of cancer mortality. So number 1 is tobacco-related lung, but number 5 is lung cancer in a never smoker, beating out colon cancer. So you can see that this really, we think of smoking as a risk factor for lung cancer, and it is, but don't forget about the risk of lung cancer in your never smoking patients, because these people are still dying of lung cancer at unacceptably high levels, and they don't meet our screening criteria. So, they frequently get found incidentally or potentially even later because they're not getting screened. Next slide, great. All right, Anne, do you want to talk about some of our exciting new things that have happened in the lung cancer world recently?
Yeah, as I was preparing this, I just thought, let's just do the top 10. So you know exactly what's going on, what's the latest and the greatest in lung cancer. And I think that if you take 3 from each of one of these sections, the absolute top number 1 is that we are making significant progress. So there's a lot of changes and in prognosis, and that really is huge. So let's talk first about non-small cell lung cancer with no driver mutation. So that's sort of typically related with smoking. As Gavitt showed, it's still our top one for patients for mortality. So I think what's important for you to know is that let's start with 3. The 5-year overall survival for stage 4 disease is now 25%, right? So it used to be that stage 4 lung cancer was a death sentence, and you better get all your affairs settled in a year because you have about a year. And that's just not true now. 25% of our patients make it out to 5 years. What does that mean? It means that some of my patients I saw last week are 7, 8, 9 years out, and they're still doing well and are free of disease. So that's really changed. And why is that? It's really because of immunotherapy. Being able to teach your immune system to recognize the cancer cells and over time really prevent any growth. And so that really started with stage 4 metastatic disease. But what we found within the past couple of years is that you can move that benefit up earlier. So for early stage disease, those are the patients that are going to surgery that Gavitt talked about before, in adjuvant ways, so after surgery or before surgery. And I still think it's amazing that there's there's a trial that had 3 cycles of chemo IO before surgery, and 25% of those patients at the time of surgery had pathologic complete response. There was no evidence of any disease. And that was compared to chemo, which the level was about 6%. So that's what we're talking about. And that's what we're, I think really is a positive message. Now, Gavitt talked about patients with driver mutations. So, and many of those are non-smokers or oligo smokers. And so I think that the message here is that you can use targeted therapy for early stage disease now. That those were the ADORA and the ALINA trial, that if you have an EGFR or an ALK mutation after surgery or after chemoradiation, you can take a pill, and you take a pill for a year or 3 years, and that leads to much, much better benefit and survival for those patients. Targeted therapy is more effective overall and in the brain. So some of you may remember that we used the early first and second generation EGFR tyrosine kinase inhibitors like Iressa or erlotinib, Tarceva. And those patients, we had to keep scanning their brains, because even though they had great control of their lung disease, they were starting to have brain mets. And then the third generation EGFR tyrosine kinase inhibitor, osimertinib or Tagrisso, has really, really helped, has better penetration in the brain. At ASCO, that's our annual meeting, there was a standing ovation for the results of the CROWN trial. So that was for patients with ALK rearrangement treated with the drug lorlatinib. And after 5 years, the intracranial disease-free population was 92%. So that's 5 years. And those patients, that was looking at penetration in the brain and disease control in the brain, but those patients are also doing much, much better over time. So it's more effective. And then, as I mentioned earlier, KRAS, we thought that was undruggable, and now there are some inroads in terms of targeting that oncogene, which is present, that mutation, which is often present in many heavy smokers. And then finally, for small cell, again, a disease where the overall survival for extensive stage used to be about 9 months. That's gone up to about, in median, the median overall survival is somewhere around 13 to 15 months. But there are some exceptional responders that do. I have a patient who had small cell in the brain initially, and she's now about 4 years out. And she's doing fine. So I think the message there is that you can now use immunotherapy for limited stage. That's after curative intent therapy with chemoradiation, and these new drugs that are now approved have promise. And that drug, the bispecific that I spoke about, has an overall response rate of about 40%, an additional 30% have stable disease. And right now, the duration of response, the median is around 11 months. So that already, in a relatively immature, we're still waiting for the long-term follow-up of that trial, has a lot of people really, really excited. And I think the other big change in small cell biology is that we're starting to think of small cell as not just all the same small blue cells, but that there are actually subtypes that you can identify and target. And so we're going to have a new trial that's opening up nationally that I'm the chair of, that we're going to take 900 patients and get their tissue and figure out what subtype they have, and then randomize them to a biomarker-directed agent plus immunotherapy versus immunotherapy. So there's just a lot of excitement going on in lung cancer. And I hope that we've shared some of that with you tonight. And then I think we have, we'd love to have some of your questions. I see some of you who have been regulars of this series, so would love to have some of your questions, maybe access, referral of patients, communication, co-management, any of those things, or if you have other questions.
That was absolutely terrific. Thank you, guys. And while I wrap this up, I'll pose a couple of questions to our audience. Please do enter questions, because that's one of the things that makes this special, is the kind of interaction between primary care and our Smilow colleagues. So, I mean, one thing that came across loud and clear is improved prognosis. And again, we've talked before about, when a patient has something that shows up on a scan or something else, how do we approach it with the patient? And how do we make sure we say the right thing? This talk, I think, really helps me to know that the script is changing. This is potentially very serious, and there are many, many new treatments on the horizon, and many people living much longer. Is there anybody who's been cured yet through immunotherapy?
I think so. I mean, I think we're always careful about saying cure, but if I have a patient who's been free of, actually 10 years, I tried to discharge my patient and they said, no, we want to keep coming back. So, Scott Gettinger, who has been here for a long time and put many of those patients initially on trial with immunotherapy. And I remember many of you know Lynn Tanui, and we spoke about those patients at Tumor Board, and that trial was immunotherapy versus chemotherapy platinum doublet, which was the first line gold standard. And I remember Lynn saying, this is not, I don't know if this is ethical. We're denying this patient what the gold standard of frontline therapy is. And we don't know whether or not that's going to work out. And Scott said it's going to work out. But I mean, you also, when you go on a trial, you know that you're going to get a staging CT in 4 to 6 weeks, and you're going to find out if it's working or not. And many of my patients who were on those early trials never got chemo because they did so well with immunotherapy. It's not to say that there aren't side effects. For sure, we've learned a lot about immunotoxicities. And we also know that this isn't the case for all people. So, 25% are doing extremely well, but then many of others will develop resistance. And so what I usually tell my patients is that, if you have stage 4 disease, it's something that we can treat. And we're thinking about the long run. So we're going to want to develop different tools for you to use. And there are a lot of standard tools, but that's when I encourage them to think about clinical trials, because we might be able to have that opportunity to give them something that is really going to benefit them and give them access to cutting edge therapy. On the other hand, I also tell them that it's not a guarantee. And so, some folks say, that's fine, I don't really want to do it, I'll take it when somebody else has worked through it. And other folks say, well, if I'm going to go through this anyway, I'd love to be able to help people in general and maybe benefit it from myself as well.
The other point that's all so important, Anne, and so true, I agree with what you said. But the other point that's important to make here is that these patients are also, whether they're cured of their stage 4 cancer or cured of their stage 1 lung cancer with surgery, this is a patient population that is at risk for developing second primary lung cancer. And so, whether you're stage 4 or stage 1, I tell my patient, you're getting a CT scan every year for the rest of your life. Once you come in with lung cancer, you are under surveillance forever, even if you go many years without, in a stage 1 patient, your cancer coming back. You are patients who have had a prior lung cancer are the most at-risk group of developing lung cancer, more than your smokers. Any history of lung cancer puts you in the #1 risk group. And so these patients need an annual scan for the rest of their life, not just for monitoring for recurrence, but really you're looking for other primaries. And this has been shown in multiple studies. One of the biggest stage 1 studies to come out that was comparing a sublobar resection to a lobectomy, so taking out less of a margin of healthy lung. First of all, that showed no difference in tumors under 2 centimeters. So we're doing a lot less surgery now, taking out fewer lobectomies and more wedges and segments. But the other thing that showed is that group of patients had like a 30% chance of developing second primary lung cancer, much higher than people were even thinking it was. But when you were following patients long-term, there's a very high rate of second primaries.
And that was a big pearl. Patients with a history of lung cancer need a CAT scan every year for the rest of their life. That's really different than a lot of the other cancers. Just to drill down on that, and then we're going to move to a question that did come in. Is that a regular CT or is that a low dose CT like we would use for lung cancer screening?
I'd feel comfortable with a low. I mean, you're really just putting them back in the lung cancer screening pool after a certain point. I think you need a high resolution scan if you're watching some sort of evolving staple line or you have a nodule of interest that you're following. But when you're really just looking for something different, I think a low dose CT scan is fine. The other thing, as surgeons, we use contrast when we're planning surgically, or you need to look at a lymph node or certain vessel anatomy. But in general, non-contrast CT scans are fine. So I like to make the point to patients, it's kind of the easiest screening you can do. Easier than a colonoscopy, no prep, not as painful as a mammogram. You just literally lie down on the table. There's no IV. It's the easiest screening scan you can do.
There's no competing for screening. It's all good.
Yes, it's all good. But us in the lung world, CT scan is the best.
Exactly. So I want to get to the question from Flora Zarku-Power. What does the future hold with 5th generation CAR T cells in solid tumors and lung cancer treatment?
So that's a great question. I talked about how immunotherapy has promise, but we know that it doesn't work for everybody. And for people it does work for, you can develop acquired resistance. So how can we juice up those T cells and the immune system to really be more effective? And so one of the ways we can do that is using chimeric antigen receptor T cells that are really that are generated. Sometimes they are generated with the patient's own tumor in order to develop cells that are oriented towards the neoantigens for that particular patient. This is still, I think for CAR T, we're in solid tumors a little bit behind the liquid tumors. So right now we still have clinical trials. So we're still working through this. I think that there's a lot of promise, but I don't think that we know the answer yet. And I'm going to ask Gavitt to weigh in too, because Gavitt actually does research on this. So
yeah, well, we've done, and also I've been the surgeon for some of these clinical trials that we've done here at Yale, where frequently we go to the lungs to find another site of metastasis from another tumor that the TILs can be grown up in. But I would echo the sentiments that this is still mostly within the context of clinical trials. It's not something that we are routinely using for lung cancer right now.
Okay, good. So we're coming to the top of our hour. Beth, I would like to give you the opportunity to ask any additional questions because you've been thinking deeply about lung cancer and care. Are there any additional questions that you have for our panelists that we didn't include in the cases that came up?
No particular order, but one question I want to ask about is, like, for example, this PD-L1 status and how, that having that expression on the cancer cells can then lead to these treatments. Is there a stage that you say, I'm going to, I can take advantage of that versus not? Like I hear you talk about, like, oh, if they're advanced stage, we're definitely going to give that a shot. But then you talk about, well, sometimes, depending on the immunotherapy, I'm going to start it earlier rather than later. So my question again is, with these particular markers being expressed, are there stages of cancer for which you would then take advantage of the immunotherapies?
great question. So if you're stage 4 lung cancer and you are PD-L1 high, you can benefit from just having, immunotherapy once monthly or once every 3 weeks, sometimes once every 6 weeks. Really, really easy to tolerate. It does have side effects, but that you need to watch out for. Those are typically treated with steroids because that's calming the immune system down, right? So if you're PD-L1 low or intermediate, then you would combine it with chemotherapy. And we've gotten some really great results with that as well. So if you're a stage 1 tumor, 1 or 2, so something that you would go to see Dr. Woodard for resection, then actually now if you take that tumor out and that's PD-L1 positive, we typically will give you a year of immunotherapy afterwards. And that's because the trial actually showed that there was better benefit. If you're PD-L1 0 or negative, we might not do that. There is a indication for that, but typically right now, if you're negative, most of the benefit in those trials are driven by patients who are PD-L1 positive. So then you have the locally advanced patients. So you have either stage 2 or stage 3 disease, and you think that they're possibly resectable because they have lymph nodes in maybe one area or maybe 1 or 2 areas. And that's where actually, I'll just hand it over to Gavitt because you were talking about that area. It's super exciting.
Well, one of my favorite numbers to quote, because I think it's important to recognize how much heterogeneity there can be within a tumor. And when you get a biopsy, you're sampling a few cells from, an enormous grapefruit or maybe hopefully smaller than that, but you're really only looking at a few of the cells. And so when you're sampling these from a biopsy as opposed to a surgical specimen, there can be some differences. And so in the Checkmate trial, Checkmate 816, among the group where the biopsy showed no PD-L1 expression at all, that group still had an 18% pathologic complete response rate on their surgical specimens. So we can't totally rule it out, but it is much less likely compared to a tumor that we know has some PD-L1 expression. So, negative PD-L1 on a biopsy, you might still hope that there's some PD-L1 expression somewhere in the tumor and potentially give the neoadjuvant immunotherapy to these patients, but definitely much more of a benefit when the tumors are expressing more levels of PD-L1.
So I'm going to wrap us up. A reminder that you will receive CME credit. There's also a survey that comes at the end when you close. If you can fill that out, it helps us know what you want to hear and get better over time. I'd also like to invite you to join us on Tuesday, December 3rd for the next case, which will be featuring Aaron Colbert, Sachin Majumdar, and Jennifer Ogilvie. And that is endocrine tumors.
Thyroid. Yeah.
Thyroid. Yeah. So that should also be really fun because there's a lot of new information and also something very common that we deal with in primary care all the time. So thank you, everybody, for your attendance. Thank you so much, Beth, Gavitt, and Anne, for your preparation and sharing your wisdom. It was really nice to hear and have all in one place together. Thanks.
Fantastic. Thank you.
Thank you.